Prostatic hypertrophy means that something's gotten bigger, the prostate. And it gets bigger because we're people, men, male gender, has a preponderance of testosterone. And the testosterone influences the prostate in such a way that it grows. The prostatic hypertrophy happens to almost all men. Some are symptomatic, some are not. We're going to give you just a real brief overview of how to recognize it and how it can be treated. Well, I don't have to say too much more. Weak stream. How are we going to understand this? Well, we're going to use a voiding diary. All you have to do is fill out a voiding diary over a couple of days, take it in, and hand it to your physician. And maybe I should say hand it to your urologist. And you can just sit there quietly while he tells you what's wrong with you. As we get older, what we find is the volume of urine that we void gets smaller. And the force of the flow, or the rapidity, or the number of cc's that flow in a second diminish. And as that happens, at certain points, even though it usually starts a lot earlier than we recognize, we become symptomatic. Here's the prostate in what we would say is a normal set of circumstances. Here's the urethra, and here's a case of significant prostatic hypertrophy and obstruction and large prostate that's encroached upon the urethra. And what are the symptoms? Frequency, changes in the way you void, feeling the bladder isn't empty, all of these things. Guess what? Women suffer from BPH too. See where her partner's going? It's the middle of the night. She's awake. Let's talk about the American Urological Association voiding index. This information is just a questionnaire. You fill it out. You don't feel you emptied your bladder completely? Well, how often do you feel that way? You have to go in a hurry? How prominent is it? How often does it happen? Can't get started? Tell us about it. Add up the score. If the score is 1 through 7, yes, you're right. You're probably developing prostatic enlargement. You ought to know more about it. You want to make sure it doesn't have a cancer in it, but it's probably BPH because it's the most common thing that happens to the prostate. If it's 20 or above, you better start looking around for some help because it's going to start having problems. It's going to start producing problems for you in the sense it's going to change the way your bladder works. Prostate's a hard organ to examine. Don't buy that one either. I can guarantee that every man in this room's prostate is within the length of my finger, and I can find it. When you need to do something about it, when number one, you understand the symptoms, and two, it begins to alter your life. How do we treat this? Well, if we're above the score of 7 on the symptom index and below 20, we can look at alternatives. We can look at medications that relax muscles in the prostate. Flomax is an alpha blocking agent. It's a refined blood pressure medication, and it was working on the muscles that tended to be unique to the prostate. Tended. Does have some influence on the vascular tree, and for certain people, they still get the lightheadedness. Uroxetrol is another. And believe it or not, Cialis, one of the 5-phosphodiesterases that are used predominantly for erection dysfunction, also have similar effects. The benefit of the Flomax and the Uroxetrol act fairly quickly. The problem with the Prostatic Hypertrophy, it takes at least 6 months before you begin to see a change. This is the resectoscope. This is the Roto-Rooter. This is transurethral prostatectomy. One of the things that's happening here is that this prostate tissue, as it is being resected, is accumulating in the bladder, and it can be irrigated out. That sometimes it's difficult to tell whether you have benign enlargement or prostate cancer. Nothing like giving the pathologist a handful of prostate tissue to tell you what's going on in the prostate, right? The other benefit is that it's usually, and most people who are adept at resection will tell you, that it's the right treatment for the bigger glands. Let's talk about the green light laser, which, by the way, I think is a very good tool. You pull it out to work on a particular problem. This is the KTP laser, which is really what the green light is. And the KTP laser has a very unique characteristic. In addition to vaporizing prostate tissues, this is tuned to the frequency of light that interacts with hemoglobin, which of course are red cells. The KTP laser, the green light, is that as it vaporizes the tissues, it seals the blood vessels. So it's not uncommon to do a green light laser, have the urine as clear as it was before you started. So here's the green light laser at work. This is the prostate, and this is the tissue that we're resecting and opening up the channel. This is one of those scopes that we can look right through and see what's going on and guide what's going on, and essentially, in this case, vaporize the prostate tissue. And when we're done, we no longer have obstruction, we have an open channel. Let's talk about a true minimally invasive therapy. If you diagnose prostatic hypertrophy early enough and had the opportunity to neutralize it before it really got rolling, wouldn't that be a good thing? And if you could do it without having a general anesthetic, and when you got done you could just get up and go home, that'd be nice too, wouldn't it? How long do you think it'll take us to get there? Tomorrow, today, yesterday. It already exists. That's what radiofrequency does. This again is our prostate. There are two probes that come out of this instrument that we can put into the prostate tissue. And then when we generate a radiofrequency between those two antennas, it creates heat in that area. Now, we don't vaporize the tissue. We heat it, and by heating it, we destroy its metabolic integrity. That's a fancy word for killing it. And this tissue eventually will atrophy or shrink. When we used radiofrequency, we heated those tissues, and then those tissues shrunk. The hole in the donut would get bigger, or in this case, our urethra would get bigger. You urinate better. Do you urinate better instantly? No. It probably takes 2 or 3 weeks, but by the end of a month, you'll say to yourself, glad I did it. If you really look at prostate surgery, 2 things pop out at you right away. One is urinary control problems, and the other one is erectile dysfunction. There's very little, if any, potential for that problem with radiofrequency application to the prostate to treat prostatic hypertrophy. On top of all that, can be done in the office. You walk in, we give our patients some Valium so they're kind of relaxed, give them a little Demerol, put an earphone on them, put the scope in, treat the prostate, takes about 25 to 30 minutes, maybe 35. Shortly after that, they're on their way home. So if we look at the symptom score index, here's what happens. The first 3 months there's a precipitous drop, and it actually continues for a bit longer. So what have we done? We talked about the most common prostate problem, even though you were thinking it was prostate cancer when you walked in. It's not. It's prostatic hypertrophy. We told you how it happened, what it did, how to recognize it, and what to do about it. And not only that, we told you when to do it. The procedures are short, they're effective, they're focused on BPH. If you suffer from these problems and you know it, you ought to take some action so you don't have to deal with it.